Welcome to the SFERE Awake Fibre Optic Topicalisation and Intubation video. This skill is one of the cornerstones of anaesthetic practice, yet mastery of it can be challenging due to the wide variety of methods in which it can be performed and the lack of a standardised approach to teaching it. Our vision was to develop a technique that would adequately anaesthetise the patient's airway without sedation and within 10 minutes. We have distilled the most relevant aspects of awake fibre optic intubation to make it one approach that is safe, fast, effective, reproducible and ergonomic. The following video will demonstrate our SFERE approach. We will topicalise the nasal and oropharyngeal mucosa and perform an awake nasal fibre optic intubation. The finer details of the technique will be discussed during the course, and detailed teaching videos are available online.
Okay, and then today we're going to do a awake fibre optic intubation with you. First thing I want you to do is to test your nostril.
We start by topicalising the nasal passage.
So what I want you to do is use your right hand to occlude your right nostril and breathe through your left. Fantastic, that looks great. And how about the other side, please?
After determining the most patent nostril, 2% lignocaine is sprayed using a mucosal atomization device.
2% lignocaine is sprayed onto your nostrils. Okay, I'll spray one in the front and one in the middle. Okay, it's going to be a little bit uncomfortable, so just bear with me. Okay. 1 mil. Okay. And then we're just going to advance this slightly. Wait a few seconds. Okay. Okay. Advance it slowly. Another one. Okay. You've done really well. Okay. Now while we're waiting for all that,
We now measure the length of the nasal passage and mark it on the cophenylcaine nozzle.
nasal passage, right? We'll mark it with, okay. So that I don't go too far. So what we're going to do now is to sequentially topicalize using cophenylcaine. Right? Is it starting to get a bit numb over there?
Yeah, I think so.
Okay, that's great. So we're just going to go nice and slow. I'm just going to rest my hand over here, okay? We're just going to slowly advance. All right, one puff.
Cophenylcaine spray is used to provide anaesthesia and vasoconstriction to the nasal passage. Each spray is 5 milligrams of lignocaine.
Up to 10 puffs. Third one. Next one. Starting to get numb. That'll work. Next one. Okay, and again. Next one. Tell me if it's uncomfortable and I'll stop. Okay.
Okay.
Good. Then next one. And next one. We're almost there at the mark. Next one. I'll probably just go one more, okay? One more. Next one.
We've now completed the nasal preparation and will commence the oral preparation with local anaesthetic.
All localization, thank you. So what I'm going to do now, Alan, is to get you to open your mouth and stick your tongue out. I'll be spraying the back of your throat, okay? I'll get you to just breathe normally when I'm spraying, but keep it all in, and then gargle for about 10 seconds and then swallow. Okay? No worries. So I'll get you to just open your mouth for me as wide as you can, please, and stick your tongue all the way out.
Using a 5 ml syringe and a mucosal atomization device, the back of the throat is liberally coated with 2% lignocaine.
Okay, that's all right. That's fine. Come on. Yeah, no worries. Yeah, just one. Stick your tongue out again for me. All the way out. Thank you. There again. Okay. Just take a break over there. Gargle. Now what we might do is I'll try and test the back of your throat to see whether it's starting to get numb or not. Okay? just going to use the tip of the magic to touch the back of your tongue. You feel that? Does it feel gagging?
We now test the effectiveness of the local anaesthetic in 4 areas: uvula, back of the tongue, and posterior oropharyngeal wall on either side of the uvula.
Okay. Alright, that's pretty good. That's got a little bit. Okay, so I'm just going to use the rest of this 2.5 mils here just to try and straighten it back. So I'm just going to rest it against your tongue. Just stick your tongue out for me, please.
If there are any areas that are inadequately anaesthetised, we can top up with extra local anaesthetic.
That's fine. Test it again. Alright. Back of your tongue. Sides. Stick your tongue out. A little bit more. So this time around, I want you to try to sort of just keep it there and then gargle 10 seconds before you go. Okay? Alright. Start gargling. 10 seconds. Yeah, that's good. Okay, now I'm just going to try to keep touching again, okay? Touch, touch, touch. Back of the throat. It's a bit better now, isn't it?
The tip of the nozzle is bent to 90 degrees, and local anaesthetic is directed more distally.
About 1 thumbnail's width. Okay, so that faces down like this. And we're going to use a total of 5 mils, where I'll spray 1 mil to the left, 3 mils in the center, and 1 mil to the right. Okay? So this will be a little bit more uncomfortable, but you should not be feeling most of it because it's all now. So I'm just going to put this inside. Just stick your tongue out for me, please. Okay, how's that? Is it okay? Okay, so I'm just going to turn to the left, go 1 mil there. Go in the middle. 3 mils. Okay, so breathe normally, stick your tongue out. It's okay. It's alright. Then the last bit, in the middle, and then to the side. All over. Just gargle. How are you feeling with that?
It's pretty numb.
Pretty numb? Okay. And how's your voice?
After that,
You told me. Yeah, it's changing a little bit, not all of it yet, but changing. So I'm just gonna test it again, okay? Just stick your tongue out all the way to me, please. Back of the tongue. Side, side. Do you feel anything yet?
I don't really touch him, but
Yeah,
it doesn't like me.
Doesn't sound like gag.
We have now achieved our goal of ablating the gag reflex.
Because we topicalized most of it, the rest of it we topicalized with the epidural canal.
Yeah.
So we'll start with the bronchoscope now, okay? Edwin, can I get you to help me with the bronchoscope? Thank you.
Oral topicalisation is complete, and we will now commence nasal fibre optic intubation. An 18-gauge epidural catheter has been inserted down the working channel of the bronchoscope. The end of the catheter is flush with the tip of the bronchoscope.
So just want you to sort of have your head in a more neutral position, so I'm just going to look here. Okay? I'm just going to insert this in. Now, anytime you feel uncomfortable, I can always spray the head. Okay? Alright. So just go through your nose. I'm just going to rest against your chin. Okay? I'm just going to look at the picture.
The bronchoscope is driven along the floor of the nose, carefully avoiding trauma to minimise the risk of bleeding.
Where's that comfortable?
I'm feeling my mind.
Local anaesthetic is sprayed via the epidural catheter at 3 different levels: epiglottis, vocal cords and subglottically.
Edwin, are you ready? Yep. Big breath in. This is the first lot of open. Okay, I feel not too bad. Pass the bubble. Okay, now we're going to spray one more lot of local. Okay. This one's going through the pores. Alright. Alright, I'm ready. Okay, big breath in. Thank you. In. Doing well. Doing very well. Well done. Okay. Okay, very advanced in. So this is into your trachea, okay? Big breath in. Tolerated it very well. So most of the topicalisation is good. So good. Okay, we're going to leave a few seconds before I advance the bronchoscopy side. 30 seconds.
The epidural catheter is now removed, and the bronchoscope is advanced carefully into the trachea until carina is visualized.
Try to visualize the carina. How you feel? Okay. Almost there. Okay, it's beautiful view of the carina. Okay. Edwin, can you help me advance the tube, please? So this is going to be an uncomfortable bit in the alley. Edwin's going to help me.
Once the bronchoscope is in position, the endotracheal tube is gently advanced through the nasal passages and into the trachea.
There's very little resistance. Also relax, dead simple. Now when the tube goes through the pulse, let's take a big breath in, please. Big breath in. Okay, so I'm just going to look through the tube and we are just above the carina, which is a good position. So I'm just going to hook the circuit up. Done very well, Alan. Thank you very much. Just going to put it on the
And then blow up the tube, and that's it.
And there you have it. The patient's airway was successfully anaesthetised and intubated using the SFERE technique. As you can see, it is safe, fast, effective, reproducible and ergonomic.